Hi, I'm Dr. Mike Evans, and with my colleague Dr. Frank Sullivan, we thought we might take a few moments to get you to think a bit about frontline medicine, or what we call primary care, and the importance of making it better. Primary care is where most people make contact with their healthcare system for most health problems, where services are coordinated from prevention to severe chronic disease, from beginning to end of life. The interaction can be with a nurse practitioner, social worker, pharmacist, emerge doc, dietitian, therapist, and so on. But for most people, most of the time, a family physician or a GP, a general practitioner, is at the center of primary care. To take the historical view on this, when society changed at the time of the Industrial Revolution, people moved into the cities, and healthcare moved into hospitals. Studying the problems of people where they live and work became uncommon. Health research became concentrated in wards and labs. When people wanted to invest the time and money into creating better healthcare, the obvious target was their local hospital, where health problems were more contained, siloed, and often more severe. This has, of course, produced many advances in medical science and should have continued support, but we think to make care better, we want to expand our research target towards a more inclusive ecology of care and direct more inquiry where most of healthcare is actually delivered, primary care, and where people live and work. 3 reasons for this come to mind. First, health systems in different countries across the world vary in the quality of family practice provided to patients and communities. Many of us think access to an MRI machine or a super specialist is a measure of a successful healthcare system. And obviously sometimes this is critical, but it's actually those countries with the highest quality primary healthcare that have the lowest mortality and highest quality care overall. Better access to family practice also tends to lead to a more equitable and less expensive system. Second, hospital priorities are now changing. Sure, it's still about providing high-quality care in-house, but hospitals that are also able to transition patients back to their homes and support them there are the ones that will succeed. This is especially true and challenging as the population ages. Third is that the solving of healthcare problems in primary care can be messier. It's the petri dish of our complicated lives and shifting personal priorities. And it's hard to point to than one clinic or hospital system, but it's also where we get out in front of disease, target a wider cascade of behaviors that help us self-care, and nudge healthy habits that help across all chronic diseases. Where problems are seen in the context of community and the social determinants of health, and where we emphasize things that matter to people such as function, self-efficacy, caregiver wellness, return on investment, and quality of life. What Barbara Starfield, the pediatrician who has led much of this research, defined as a broader concept, taking into account how people feel about their lives and what they're able to do. It's not that there is no research in family medicine, but there are many more unanswered questions and incredible opportunities to have a wide ripple effect. So, for example, one line of research into minor infections in Europe has shown that half of all cases of sore throat and urinary infections need not be treated with antibiotics. Another large project in Canada called Better, and led by Dr. Eva Grunfeld, where primary care practices were helped to help themselves, improve care by 37% across a wide range of services, from better prevention and screening for several cancers to reducing chronic disease like heart disease and diabetes. One emerging strategy is practice-based research networks, or PBRNs. These are living laboratories that partner frontline care providers with academic researchers. Research questions emphasize the practical and typically answer questions that might be at the top of the list for frontline providers and patients. One example is Utopian, the University of Toronto's PBRN, where we can actually map disease in our own practice in multiple clinics simultaneously through smart electronic records. This allows providers and approved research teams to innovate across the continuum of care. When patients come in with bad back pain or cough or headache, are we providing best practice? How can we get people at high risk into cancer screening? Perhaps there's a way to diagnose lung cancer earlier, or testing a new medicine for diabetes, or maybe a better way to explain the value of exercise. Once we can measure, we can see what works for our patients and what doesn't. With Utopian, U of T can now make small improvement tweaks, experiment with different practices, and partner with others in real time to make primary care better. Albert Einstein said, insanity is doing the same thing over and over again and expecting different results. Can we shift from one-time snapshots of practice to following common problems over time? Can we look more upstream at illness before it gets to the hospital? Can we have systems in place so that when we tweak one practice or 20 practices, we can see if it helps? Can we innovate care where it actually happens? Food for thought, and thanks for listening.